Now we're going to go to San Donato. Hello, Gianfranco.
Hello, Carlos. Nice to hear from you.
Yeah. How's everything? Let us know.
Yeah, things are doing well. I hope the same for you. So I would like to thank all people here in the Cath Lab, Silvia, Lucien, Viera, Giovanna, and Merit, our anesthesiologist. And I should I should give the possibility to Nidal to present the case. That is quite tricky one.
Okay.
Please, Nidal.
Okay. Thank you. Good afternoon. A 37-year-old female with postnatal diagnosis of pulmonary atresia with VSD and disconnected pulmonary arteries. Body weight 50 and height 160. In 3 and 6 years of old, she had a modified BD chant. In 9 years of old, the cardiac cath showed an absent right pulmonary artery with pulmonary hypertension in left pulmonary artery. In 22-year-old, intervention of unifocalization of the MAPCAS on the left pulmonary artery with 19 aortic homograft and partial closure of the VSD. At present, the patient is symptomatic of dyspnea with NIA 2 to 3. The saturation is 71%, and on 6-minute working test, we note a severe desaturation. On chest X-ray, cardiomegaly with severe calcification of homograft. We see here the echocardiography. So, mild tricuspid regurgitation with estimated right ventricle systolic pressure of 90 and dilated and hypertrophic right ventricle with mild systolic dysfunction. A small subaortic VSD with mostly right to left chant, a dilated left ventricle with mild systolic dysfunction with mild to moderate aortic regurgitation and dilating of ascending aorta. On cardiac MRI, we see a severe dilatation of right ventricle with an diastolic volume of 154 and moderate to severe systolic function of right ventricle. Here we see a severe stenosis of the homograft. The cardiac cath showed a suprasystolic pressure in right ventricle with a severe stenosis of the homograft and a moderate to severe pulmonary hypertension with pressure in pulmonary artery of 60, a normal wage, a normal cardiac output, and a high pulmonary vascular resistance of 28 Wood unit. After nitrite oxide testing, we show a decrease in pulmonary vascular resistance and of pulmonary artery pressure. We see here the angiography. So, Dr. Butera?
Yeah, thank you, Nidal, for your very nice presentation. And Carlos, as you see, there are several issues about this patient. History of pulmonary hypertension, degeneration of homograft, and there is a significant gradient across this homograft that is around 60 millimeters of mercury. During the last cut, we pre-dilated a bit with a balloon, a crystal balloon 8 millimeters. And now I would like to show you what you have done until now. But first, ask for your comments and suggestions.
Well, I agree with the plan number 1 and 2. I think we should provide a combined therapy. We should restore pulmonary valve competence and give this patient some pulmonary vasodilator and see if there's some remodeling over the years. I think they get better if they get a competent pulmonary valve, even if they have pulmonary artery hypertension. I wonder what the panel think. The audience.
I agree. Hello,
Gianfranco.
Hello, Andreas. This is Andreas.
Good afternoon.
I think if you can reduce the pressure gradient between the right ventricle to the pulmonary artery, you will do some good for the right ventricle. So I agree with Carlos.
Of course, you will never get a normal pulmonary artery pressure and resistance in this patient, but if you add limited intervention here and combine that with vasodilator therapy, the patient might improve. But it's quite a challenge.
Yeah, I agree. So
anybody
we may
in the audience who has experience with this kind of clinical scenario, which is very unusual. Kevin, Peter, you've been doing lots of patients with pulmonary hypertension.
Philip, I think Felix group published a series with pulmonary hypertension, and he could show that patients really improved by treating them, even though they had pulmonary arterial hypertension.
Yeah, these post-operative MAPCA patients with conduits, I think it's important to revalve them. You know, and the pulmonary, bosentan and sildenafil afterwards will help a good bit too.
Okay. Okay.
So
Thanks.
John is coming to the mic.
Okay.
It seems everybody's on the same page. John.
Yes, a similar patient of Larry Latson that was referred to us had MAPCAs and bad pulmonary hypertension, lost a lot of segmental arteries with residual VSD left open, had bad pulmonary regurgitation, was cyanotic and symptomatic, and through the diastolic flow through the VSD, and got revalved and symptoms improved, had hemoptysis and some other things and improved. And then we've had other patients, because the RVEF was 32%, and that's not going to get better with unrelieved stenosis. So relieving the stenosis, you may have improvement in symptoms, number one, and then you can safely treat them with pulmonary hypertension medications.
Okay, thank you, John.
Evan?
Just one more thing. We too have the experience that you've heard already, that these patients get much better. I would just add a little word of caution for wire position. We've had one of our pulmonary hypertensive patients that had a very tiny wire perforation that in a regular patient wouldn't have been a big deal and was nearly fatal, I think, due to the pulmonary hypertension. So just gentle with the wire. The other thing is we wrote a report a few years ago about how nicely Melody seems to function under high pressure, including pulmonary hypertensive patients. So it's a good long-term solution as well.
Very good points. So Gianfranco, can you show us the pictures?
Thank
what
you,
you've
thank
done
you.
so far?
Thanks for all comments. So let's show you the picture we have done so far. This is a 9 French Malins sheet just below the valve. You may see that there is a huge amount of calcification that it is possible to be seen in both lateral and AP view, and it was quite difficult to get through this valve to this calcified valve. So we pre-dilated that by using a crystal balloon 10 millimeter and long 40 millimeters, and then another crystal balloon that was 15, and then again we went on in putting in a high pressure balloon, an Atlas balloon. This is the ascending orthography in AP and lateral view. May we see also the AP view? Okay, this is the AP view. The left coronary arteries looks not very close to the conduit, but we should check that. And so we put a Atlas, high pressure Atlas balloon, a 20 millimeters high pressure Atlas balloon, but it happened that it broke 2 times. We were able to have this kind of picture, as you can see here on the screen, with the pressure on the inflator up to 6 atmospheres, and we are next one. So that's the first inflation. That's the second one. You may see at the bottom of the balloon there is some contrast going out of the balloon. Next one. Anyway, the left coronary artery looks quite far from, but we do not have tested really properly this conduit. What are your suggestions at this point of the procedure?
Well, Gianfranco, it's Peter here from Munich. I think you were really lucky that the balloon was breaking and not the homograft.
Mm-hmm.
Because in a similar patient, we had a fatal complication where we, where we overstretched such a calcified homograft and it broke in the inner curvature completely, like a cup of porcelain, and there was a massive bleeding which we couldn't control. So if we are quite sure that the coronary is not an issue, especially because I think that the diameter of the distal calcified homograft is the diameter we want to achieve, so we don't need to dilate it there, I strongly would recommend to place covered stents to cover all these calcifications, and then you have a shelter so the balloons will not longer break, and you have you are on the safe side with regard to cracking up this calcified tube.
Okay, so you suggest to implant a covered stent first and then redilate a bit if needed.
Yes, exactly. And I would take a long covered stent or even two covered stents to cover all these calcifications.
Okay. Any other comment from the floor?
So, John, Evan, you guys don't have cover stents available to do a preemptive approach. How would you manage that in the U.S.? In Brazil, I mean, we do have them, but they are not covered by the health system. So, would you go with a regular stent, and then if something bad happens,
no, I'm with Peter. I don't think you. First of all, I wouldn't worry about this coronary at all. We don't balloon. I don't want to just say the wrong thing, but we don't do every case with balloon when it's this far away. I think you take risk, and I don't think you do this case responsibly without covered stents in the lab. So in the States, it is cumbersome, but we now have ways to have covered stents, and you know this patient coming in just by chest X-ray is going to have a terrible problem with calcification. So I really think if you don't have covered stents, you don't do this case. It's too dangerous.
So Gianfranco, what are you going to do now?
Okay, so at that point we just go to measure what we had there. I would like to have a diameter of this stenosed area. The balloon is at 20. I don't know if we reach the nominal diameter on both sides of this stenotic area. No, tu puoi prendere I due marker da 20. Just to have an idea of which kind of covered stent would like to use, which diameter. I think that the most crucial area, critical area, is that area where when there is this angle between the right ventricle and the pulmonary artery. Do you agree with that?
Can we see the measurements again?
Yeah, they are trying to do the measurements. So the distance between the two markers is 20, because this is an atlas.
We don't see the screen.
Yeah, may we see fluoro, please? Yeah. 20. May we see fluoro, please? Okay, okay, so they've calibrated on the two markers of the balloon, and then they are going to make a measurement of the balloon itself. Okay, so we have 16 or 17. So what do you think? We could put a covered stent. We have 45, is that true? 45 long and 18 or 20 covered stent on a pre-mounted B balloon.
There's just one point, Gianfranco. The conduit, the calcified conduit above the balloon is a lot bigger than those 20 millimeters.
Yeah, you are right. We have measured before up to 25. May you measure?
The first step should be to cover the calcification, so it is not an issue how small the dimension is at the smallest point. Just take a large balloon and then adapt the stent into this calcification without any impact on the stenotic area, I would suggest.
How big a balloon? 20?
Yeah, it depends a little bit on the distal dimensions of the calcifications. If this is, let's say, 25, I wouldn't mind to take a 26 millimeter balloon just to be sure with low pressure to cover all this. It's only to place the stent firmly to the calcification, not to dilate anything.
So you should cover from the distal part to the proximal part. I think that the most crucial part is right the part where there is the waist there on the balloon. So I should cover this part. I mean, even if the stent is not distal, is not completely in place. I mean, over the wall, we are not going to stretch the wall at this point. Il tronco polmonare.
Gianfranco, it's John.
Yeah,
I think that the critical point is covering the lesion. It doesn't make any difference.
Because
I would not use it.
Do you see the measurement? Do you see the measurement? It's really quite big.
31.
We will not be able to.
But that's the measurement of the calcification. You haven't shown what the vessel is at that point. The point is you need to cover the area where the rupture is most likely to occur.
Yeah.
The 45 millimeter long. You're going to put it on a bib. Bib will not expand that covered stent bigger than that 16 diameter. It's not going to happen. It's a Z-med. So you just lay the covering in to cover the area where you're worried about rupture, and then you work with that, whether it's one stent or two stents. We've done two stents a lot of time to extend the length, and then you start dilating it. You're not going to dilate it with the balloon you've delivered is not going to make it any bigger than that. And then you start working as soon as you've safely covered the area of concern. I don't worry about the distal part.
Okay, I agree.
You're not going to be up.
I agree with you, John.
I do not agree at all, because it is not the case that the nearest point will break. Of course that will break. However, you have a very stiff construction of this homograph. It is one entity. And if you have a look to your high-pressure balloon now, this high-pressure balloon, if you go up to 22 or even more atmospheres, it will be like a bar in this very stiff structure of the calcified homograph. Then it is unpredictable where it will break. Of course it will break at the smallest point, but it can, because you have a really big forces inside, it can break up at any point, like if you take a cup and put it on a stone, and then you have a lot of pieces. And in that way, the crack inside this homograph can be even on a more distal part and not only in the smallest part. And I would like to have a comment from Andreas, because I think he's an expert in this experience.
An expert, because I've lost this one patient Peter is just referring, and it happened exactly that. You know, that was a homograph that was 26 millimeter in the distal part, and there was a tight narrowing, and I cracked it, and it cracked unpredictable. We couldn't save the patient. So, of course, this is just one patient. But of course, if you experience something like that, you're quite touched by that.
So, what is the suggestion of coming from you, panel and floor?
I would take a 45 millimeter covered stent and put it at least on a 24 millimeter balloon.
Okay. We may do that, but okay. Even if we will not inflate completely, we will have a waist, but we shall cover.
Or you can put it on a 22 on a 22 millimeter balloon, and then flare the end with another balloon.
Okay, just to protect the conduit itself. So we shall do that.
Mario?
Yeah.
Mario.
I'd like to make a comment. Yeah. I mean, I think that it's going to be impossible to inflate a cover stent opposing to the wall in the distal part of this conduit. It's too big. I mean, there is no way to expand a cover stent up to 31 millimeter. So I was a bit worried about to stretch this calcium in an excessive way. You expand the balloon there is a residual waste, and I will try to put a cover stent about that size first. Forget about the covering the entire length of the calcified conduit, because it's going to be impossible. I would like to have some comments from Andreas, Peter, John, and everybody. I mean, you cannot cover the entire length of this conduit.
I also think that you can't, the end is too big. I agree with Mario. The end is so big, you probably cannot oppose the stent to the calcification.
So my plan is... sorry.
No, go ahead, Gianfranco.
No, go ahead, Carlos.
I think the stent itself, it doesn't go more than 24 millimeters, up to 25 max, with the risk of tearing the EPT FE coverage. So, well, there are clear two approaches here. One with an oversized balloon, trying to match the size of the more distal part of the conduit, and maybe a more, less aggressive kind of implantation initially, with a balloon maybe anywhere between 18 and 20.
Yep.
Carlos, or the point I was trying to make is the 45 long, where the most likely place. Like I said, I don't, in all due respect to Andreas' experience and everything, I think the distal lesion, can that rupture there? Yeah, but you shouldn't be in that area. You're trying to relieve the stenosis. Stenosis is right there. You're going to put this in on a 22 ensemble. That's most likely it's going to relieve the stenosis. It's going to be there. The 45 long stent is way longer than the melody valve. Once you protect that area, you don't care about the other part. You shouldn't even be dilating the distal part. So you just put the melody valve in the anatomic position, and you're not dilating the distal part. So, I mean, you can rupture it, sure, if you use too big a balloon. That's not really you're going to put a melody right where that stenosis is once you treat it with the covered stent. You're not going to put a covered stent all the way out to the branches.
Joaquin?
I agree also with John. And honestly, what I would do personally, I would do exactly that, putting a long stent, oppose it as much as possible, proximally and distally, and leave it like this for today. I think Peter is right. This thing is a porcelain, and it can break, but it can break today. If we leave a membrane on place and we let this endothelialize against the calcium, you can drop the cup, the porcelain. It's not going to come apart. You're going to have cracks, but you can still drink inside.
Mario?
Yeah.
So I would leave it. I would prepare it, pre-stent it, and that's exactly the case. This would solidify the porcelain, and then if it cracks, it's not going to bleed as much as if you do it right today. I don't know. I would probably not do it in the same day.
Well, in addition, I would like to add another comment about that. Because of the extensive calcium and the curvature of the conduit, I would avoid a too much long balloon, because when inflating the balloon, particularly if there is a high pressure balloon, you may stretch the conduit, and indeed rupture may occur distal. So that's why I would avoid to use a too much long balloon. You just put a stent there, relieve to some degree the stenosis, and that's it.
Yep.
In other words, I will personally try to be very conservative in this case.
But do you mean just put a covered stent and not a pulmonary valve, or put a pulmonary valve? Because there is already a significant degree of regurg.
Yeah, that's right. Where the stenosis is, Gianfranco, put a cover stent, put a melodine, relieve the stenosis and abolish regurgitation, and that's it.
Yeah, I agree with that plan. My plan could be to go with 18 millimeters, 45 millimeter long CP pre-mounted stent, because we have measured that the stenosed area is around 15 millimeters, so we will not stretch so much this conduit, and then put a melody valve in. Everybody agrees?
Can I have a question, please?
Yeah.
Raul Rossi from Brazil. As much as I would like to leave, the idea of Joaquin to let it settle and scar and make things firmer, I think once you have pulmonary hypertension, the end-diastolic pressure, even 6 months will be very bad for this patient.
Yeah, I agree with you. I mean, the right ventricle will not tolerate an increase of regurg that will be quite a significant one. Okay, sure. So I don't know if you want to stay connected or we work a bit and then come back to you.
I think it's a good idea that you can work in peace now, Gianfranco, and just tell us when you want to come back.
Okay, thanks a lot, Andreas. See you soon.
Okay, we're just ask for your patience because we're going to go live to Gianfranco again.
Yep. Can you hear us? Hi, Carlos. We had the possibility to hear this very nice and wonderful presentation. And in the meantime, we were working with a good patient, thinking about what's going on in the soul of people. So we would like to show you angios we have done till now. So we have decided to put in place a previous one, 18 millimeters, 45 millimeter long covered CP stent, pre-mounted CP stent. Next one. Okay, here you may see the inflation. Next one. This is the injection in the lateral and AP view. So no major breaks here. Next one. And now we are ready with a melody valve, ready to be implanted. We have chosen a ensemble 20. And you may see live the fluoroscopy with the system ready to be implanted. Any comment or suggestion from the floor? I think that the position looks good to me. What do you think?
Yeah, it looks excellent position so far there, yeah.
Okay, so we go ahead because also you would like to attend the gala dinner. And you too, I think.
Yes. Just to let you know, there's a large audience still, so you're not on your own or
okay.
Not just the three members here.
Okay, thanks. Spingi un po' la guida. Okay, so we are uncovering the stent valve. Okay, it went a bit further, but we can come back. And so this is my position. Okay, do you agree?
Yes. Yep.
Okay, so we inflate the inner balloon first. We show that on Cine for you. Okay. And now we go ahead with the outer balloon. Position is okay. Okay, go ahead. Go ahead. We make an hand inflation. So, stop. So we can modulate the force. So the stent is still there. Okay.
I didn't want to interrupt earlier on, but after the initial stenting, what was the RV pressure out of interest?
Yeah, we shall show you the pressures. It went down significantly. It was a bit less than systemic. So we may put the 18 French dilator. We can pull back all the system and make rapidly angios and hemodynamics for the patient and for you. Okay, pull back, pull back. We try to leave the wire in place, okay. Okay, oxygen saturation increased compared to the beginning of the procedure when she was in the 70s. Now it's around 88. Okay. So we are putting in place a 18 French Gore introducer, which has a valve, inflatable valve, at the bottom, so we can really, okay. So, please, l'introduttore via, introduttore, il dilatatore.
Current
so
picture, Gianfranco highlights the fact about the earlier discussion of how big that calcified area is distally, and so how difficult it would have been to put covered stents
yeah. Probably a out-expanding system, I mean, covered stent could be have done the job, but not a balloon expandable. Okay, so we put a Malin sheet, a 9 French 9 sheet, Malin sheet. Sorry.
Gianfranco.
Oh, okay.
Yeah. What you observed in this patient with the saturations going up is what I was describing with another similar patient with Down syndrome and pulmonary atresia VSD MAPKs with pulmonary hypertension, and had diastolic. They had primary pulmonary regurgitation with diastolic right to left shunting through the VSD, residual VSD, and their saturations immediately improved. And you know, as Dr. Somerville pointed out to our surgical colleagues, leaving someone like this with some degree of stenosis without regurgitation is probably not such a bad thing.
Yeah. Okay, so we are ready to record pulmonary pressures and then make angios to be sure that everything is okay. So just start with the pulmonary pressures, and I can do a pullback also, un ritiro. We should need to give a look at the angio and the pressures, angio and pressures. No, ce l'hanno di là. So pulmonary pressure increased. It was in the 50s before, so we have somehow relieved it.
Pictures bigger.
Yeah, I cannot see the picture you are looking at. Okay, so that's perfect. Okay, so I made the pullback.
Can we see the pressures?
Yeah, there is almost no gradient across the stent. So we are ready to do 2 angios, even a bit more. Yeah? Are we ready with angios?
So maybe,
let's go.
10 millimeter gradient, maybe 5 gradient.
Okay. So this is...
Now we can look at the angios.
Please have a look at the angios. Okay, this is the lateral view. Let's give a look at the AP cranial. Okay. It looks okay for me. I would like to go to the pulmonary artery just to make an injection there. Okay. Okay, pull back the...
Did you do that last angio in biplane, Gianfranco, or just that single plane?
No, we have just a single plane.
Oh, right, yeah.
So we should do two injections. Okay, so we are here in the pulmonary artery. Okay, ready? Okay, no pulmonary regurg. And I would also check in an AP view.
Wasn't a very good angio, Gianfranco.
We have injected 30 cc at 18. So
yeah, a bit too high.
Probably too high. I can do...
You don't have to convince us.
Okay, if you want. Anyway, we shall do another one just to check for pulmonary artery. Right? And I am bit back now. Okay, there is no regurg and there are no extravasation. There is no extravasation to me. So it could be enough, I think.
Yes, I think that's an excellent result, considering we were worried about the eggshell cracking.
Yep.
You've done an excellent job there.
Yeah, I think also that it was a good idea to delay the starting of vasodilators, because in some way with these, high resistances, we could be protected by a reperfusion injury. Anyway, we will check the patient and see what's going on.
All right.
Any comments from the audience? Peter, are you happy with the results?
Yeah, Peter, Andreas, you wouldn't pull out your 26 millimeter balloon yet, would you?
I think it's a good compromise.
Yes, that's what I mean. You just don't want to hurt the patient, and because they wouldn't survive a complication.
So.
Yeah, so
it's
Gianfranco, Peter's happy about you not breaking the egg.
Okay, that's perfect. I'm happy too.
Okay. All right, Gianfranco, stay on the line, but thank you very much. Thank the whole team there for an excellent demonstration of this very difficult patient. So well done on that one, yeah?
Thank you. Thanks a lot. I would really thank all the team here and also the people taking care, the doctors taking care of the patient in the ward. You have not seen them, Dottoressa Negura, Dr. Saracino, Dottoressa Nidal, and other people in the ward, but they are really very precious for us. Thank you.
Gianfranco, can you tell Lucianne that she's safe now because Neil's flight has taken off?
Okay. Okay, tell
she's
them.
Very safe.
I tell her.
Okay, but stay on the line. And Mario, can you come to the front, please, just towards the stage?
Mario.
So this, if I could ask for your patience just for a few more minutes before you run off for the dinners. This was the last live case. You will all agree that, firstly, it's very difficult to organize these meetings. It takes a lot of hard work. It's not just one person. There's a lot of stresses involved in all of this. Preparing the cases, it's stressful for the catheter labs, both locally and internationally. So it really is an enormous amount of hard work that takes more than a few weeks of planning. And on behalf of the faculty, especially the overseas faculty, but also on behalf of all the faculty, we really wanted to thank Mario and the whole team, the audiovisual team, the organizers, the various hospitals from which the cases were being transmitted, and the whole gang of you for a fantastic meeting, which has been highly educational. The audience participants have really appreciated it, the whole wide variety of cases that we've seen. It's been a fantastic few days. Really, personally, I wanted to thank Mario. It's really a privilege to be invited to this sort of a meeting, and your meeting in particular. And so I'm always grateful to be invited, but I'm sure John and Carlos can say words for themselves. But thank you very much once again to all of you. Thank you.
We were just talking last night, Sharon and I, and like many of the people in the room, we attend a lot of the meetings, both in the States and out of the States, and we've been privileged or unprivileged to try to organize meetings and how difficult it is. And Sharon and I were mentioning last night that this one meeting is always our most favorite meeting that we go to, this particular, all of the things that Mario and your staff do to make this an ultimate professional encounter for all of us, faculty and all the attendees and all the education, and just the congeniality, I think, of the whole staff is just fantastic, and we're very, very fortunate to be here.
Yeah, I agree. And then we've been involved in meetings, organizations, and we know how difficult it is to organize a wonderful meeting like this one. So on behalf of the South American interventionalists and Latin American interventionalists, I would like to say thank you. It's been a blessing to be here and participate as a faculty or attendee, whatever. So I would like everybody to give a big hand of applause to Mario and all the San Donato team. Thank you. Thank you very much.
Thank you so much. Thank you very much, my friends. I'm really moved, and thank you for your great support, not only for your professional skill, because you're outstanding scientist, but I want to thank you particularly and more for your friendship. So thank you very much again.
Mario, all of this was not really an attempt to make sure that we get fed this evening with an excellent meal. We hope we will, but that was not the intention behind this.
Yeah, don't worry about that. We'll take care of it.
Okay.
All right, thank you very much. We've finished now. You can go.
Thank you.
Franco, let's have some wine.
See you later. Bye.
See you later. Bye.